Hi, my name is Qisheng Zhang. I'm a medical doctor and a professor of gastroenterology. Now I'm working at the branch of Shanghai First People's Hospital, affiliated to Shanghai Jiaotong University. Colonoscopic polypectomy is a cornerstone of effective colorectal cancer prevention because it allows the removal of precursor lesions that may progress to cancer. Nearly 25% of in-the-world colorectal cancer may be owing to incomplete polypectomy. Currently, for colonoscopy, the endoscopist's attention is mainly focused on the treatment of larger colorectal polyps. Actually, in clinical practice, the polyps mostly encountered are small polyps. Small polyps contain a high risk of advanced lesions either. Ensuring a complete resection is crucial to reduce the risk of in-the-world colorectal cancer. Considering available studies for small polyps, little data is available about the rate of complete resection and the optimal polypectomy technique. Currently, polypectomy technique used for small colorectal polyp is highly variable. Cold forcible polypectomy is simple and convenient. Nonetheless, the rate of complete resection is low. Cold snap polypectomy (CSP) is recommended to remove small polyps for high complete resection rate. However, for some non-polypoid polyps, it's not easy to define the margins of polyps and snap the polyp completely. Through submucosal injection, the polyp is lifted on a submucosal fluid cushion, which provides a safety zone and facilitates snap resection. To determine which technique is optimal for complete resection of small non-polypoid polyps, we randomly and prospectively designed this study to compare endoscopic mucosal resection (EMR) and CSP techniques. During colonoscopy, when a small polyp is detected, completely and safely remove it is the best and the simplest strategy to treat it. No further investigation technique is needed to judge the nature of the polyp. Even some advanced imaging technologies such as high-definition endoscopy, conventional or virtual column endoscopy may help to characterize detected lesions. The quality of colonoscopic polypectomy remains the most important factor in determining efficacy of screening colonoscopy. In the current study, we performed 5 biopsies from the margins and base of the polypectomy site. This method is safe, simple, and reliable for the evaluation of complete polyp resection. More interestingly, we demonstrate that EMR is significantly superior to CSP for achieving complete endoscopic resection of small polyps. Also, it does not increase the procedure-related adverse event or the mean procedure time. Sometimes it's difficult to achieve a satisfactory submucosal injection for some non-polypoid lesions located behind the fold. Recently, carpal-assisted colonoscopy was proposed as a technique to improve adenoma detection. This technique is a transparent hood that is attached to the distal end of the colonoscope and allows depressing the cooling folders to visualize the hidden polyps behind the folders. Carpal-assisted colonoscopy may facilitate the submucosal injection of polyps behind the folders. Still, a prospective study is needed to testify this hypothesis. Until now, the definition of a complete resection rate is diverse. The advantages and limitations of these definitions have not been tested. We believe the consensus on definition of a complete resection rate will be achieved in the future. Small polyps are mostly encountered during colonoscopy. Patients with small polyps have a high risk of advanced lesions. All small polyps should be completely removed. Compared with CSP, EMR is the preferred technique for the complete resection of small polyps. Thanks for your patience.